Hello, good morning. Welcome to our webinar today. My name is Leeander E. Alexander. I am a healthcare administrator and CEO and founder of Edward Lee Consulting. Today, the webinar is entitled Census and Strategy, Real Talk on LTC Long-Term Care Admissions. Today, we're going to be um, going over some strategies for common challenges that long-term care admissions and marketing face. So get your notepads ready, get your pens ready, get your questions ready. Let's get to work, shall we? Now, a little bit about myself. Again, my name is Leeander Alexander. I'm a healthcare administrator and consultant and public health specialist. I have over 15 years of experience working in healthcare and public health with 10 years in management. Okay. Bachelor's of Arts in Sociology and Anthropology. I graduated at Colgate University whoop, whoop, in 2012. In 2019, I graduated from Colorado State University Global Campus with a Master of Healthcare Administrator. By that time, I was have like maybe 3 or 4 years into um, management at that point, and a good maybe 7 years or 4 or 5 years into the field overall. Um, And at that point, I knew I had to get a master's to further my career. So I came across healthcare administration, which I absolutely loved because I like being able to manage systems, figure out solutions, build business development that provides quality care to patients. Okay. I have experience working in long term care facilities, nursing homes, psychiatric facilities, community organizations, hospitals, clinics, government agencies, public and private sectors. I've been kind of throughout the field, community health, social service director, administrative director, housing management. I was doing social security disability law at one point, doing some work there. I'm really active within the public health and healthcare field, and that's one of the reasons I started Health Edward Lee Consulting. It's because I really want to really target my skill set to individuals, to facilities providers, and to patients to really improve our healthcare system through efficiency, innovation, improving care for patients, and improving public health and community health. Okay. My skill set is in risk management, program and service development, and support. Um, so, just a little bit about me. Welcome to today's webinar. Okay, what are we going to be covering during this webinar? So, we're going to be identifying we're going to be identifying some leaking points in your census and how to plug them. So we're going to be talking about what leaky points is, uh, what they look like, and then give you some quick solutions to fix them that you can use today. How to collect and utilize data to develop strategic and targeted marketing for new referrals, improving and developing internal processes, utilizing your local community for marketing, outreach, and referrals. Okay. Who is this for? Anyone who is in long-term, um, long-term support services. Sorry, getting tongue-tied. Marketing coordinators and admissions directors, long-term care administrators, long-term care management executives, or professionals looking to enter the long-term care field. This is a great training for you. Again, we're going to be covering some common challenges that admissions directors and marketing coordinators face in terms of getting heads to bed, patients in the building, keeping those patients in the building, and how to turn those referrals into a yes. Okay. So, again, get your pens, get your pads ready, and here we go. So, I want to start out with talking about the role of marketing and admissions in long term support services. Okay. The marketing coordinator director, their major responsibilities includes managing referrals and is the community liaison. I like to think of the face of the facility, attends various marketing and community events to source for new referral leads, main point of contact for referral sources. Okay, so a lot of times in the field, a lot of the marketing coordinator, director, liaisons, whatever titles they might have, they're the main ones going to the different hospitals, engaging with the discharged social workers, engaging with the hospital staff, the care management team there for potential discharges, either for short-term rehabilitation or for long-term care. They'll also work or should be working with other community organizations, which we'll get into a little bit later, to get those referrals in. So they're like the person who's following leads. Where can they get new patients for the facility? Um, because patients, you need patients in the facilities to make money, right? Which these skill sets we're gonna learn today will help you do that. Attends various marketing and community events to source for new referral leads. Main point of contact for referral sources. Oftentimes over referral management. Okay, so they're the ones who's again sourcing for leads of the community, doing marketing events. They might be attending luncheons, um, different seminars. Um, might be some looking at this training right now, even. Um, but they're basically again they're getting their face in the community. They're the face of the facility of the services. So they're out there putting the voice of community. Hey, we're here. We're doing care. We're providing care. We're providing services. Come to us. Getting patients in the building. Right. They're usually the main point of contact for the referral up until the handoff to the admissions director. We're going to get into a little bit about what or who the admissions director role in a minute. Um, So up until the times where if they're in the hospital, if the patient's in the hospital, they're in need of short-term rehab or they need a long-term care facility where they're going to age in place, the marketing coordinator, director liaison, usually they're working with the hospital staff, whether it be the case manager, the social worker, the discharge planners, whoever have you, um, to get the resident placed, to get the patient placed in a facility. So the marketing director, coordinator, liaison, they're there because they want to get that referral in their facility. They want to get that patient in that facility because head to bed. Okay. One thing you want to know about this is head to bed. Okay. Head to bed, head to bed, head to bed means revenue. So that's going to be the number one goal of any marketing coordinator and director, head to bed. Okay. The marketing coordinator and director may also be responsible for social media management, which we're going to get to a little bit later because actually there's not a lot of social media management going on in the industry. And I'm wondering why. I'm really wondering why. But those of you who are those facilities who are a little bit or are getting hip, they are starting to get Facebooks, Instagrams, um, YouTubes. Well, I haven't seen too many YouTubes, but the most famous popular one I've seen is Facebook. They usually use the Facebook for activities to showcase events, but it's very few and far between. Often, as of course, the major holidays, there's no community engagement. Okay, but usually the marketing director they might be over that. They might be over any flyers or pamphlets. They're usually the main thing they'll usually might be assisting with is the development of the flyers, pamphlets, brochures. If the administrators or owners are investing in doing that, because I know a lot of times a lot of facilities don't even do that. They just think, oh, we could just get referrals from the hospital, not understanding how marketing works. Okay, you can't just rely on the need for service because okay, we work in healthcare. Um, our business is to care for sick patients in any manner or form. Okay, we make money off that. That's the healthcare business. That's the healthcare model. So facility providers, you want to get patients because hey, you want to be like the goal is hey, if something's going on with you medically or if you need care, we can provide the care you need. Okay. Um, with that being said, for I find with a lot of long-term care marketing and admission strategies, there's just kind of you're just sitting there and waiting for the patients to come in. Because of course there's always going to be a need for short-term rehab. There's always going to be a need for long-term care. But you're wondering why your your pipeline is few and far between, why you have ups and downs, why you're getting risky patients, while you're doing all these things because you're not managing your marketing funnel. You're not managing your referral management system. You're not actually getting community engagement. You're not actually doing the engagement part of marketing. Okay, I think when people think about marketing, especially in healthcare, you're just thinking about ads. You're thinking about just the need for care, which is always be there, and the ad, like, hey, we're a long-term care facility. That's it. Or we do short-term rehab. That's it. There's no umph. There's no, why. Why do I need to go to you? It's more than just me needing short-term rehab or needing a safe place where I can age in place, or my loved one can age in place. Why do I need to go to you? Okay. So marketing coordinator director also too might be over more than one facility. Usually there's a lot of structures where they might be working for under the corporate shindig, depending how we okay. So it might be over the whole all the buildings under the corporation. Though there's gonna be kind of like a main honcho, then maybe like the branches or like liaisons under them. So but that is the marketing coordinator and director's role. Now let's go into the admissions director. Okay, so usually they're only responsible for one facility, usually. Handles the administrative paperwork, think contracts, think sometimes I have been in some nursing homes where if they have some business office capability or business office experience, they'll have the admissions director also doing like social security sign-offs and handling that. There might be some handling insurance, or at least initial insurance intake before that passes off to the business office manager. So that certain things where that could vary, but the main thing definitely is going to be the contracts. Okay, the contracts is what is, of course, the contract that the patient resident signs when they first enter the facility. That they sign off on agreeing that they agree to the care and services that the facility provide, which every patient resident has to have. So that's really hardly the number one major paperwork um, out of anything is going to be that in terms of between the resident and the patient is going to be that. They also usually are responsible for making sure all the admissions intake paperwork on the administrative side is in place. So that can include the PASSAR, the OBRA, um, social security card, identity cards, especially for long-term care residents. You want to make sure you have all that on file. They'll be responsible for really help building the patient's profile, administrative profile, at least initially, getting all that together and making sure that's in place. Sometimes I also usually uh, when I was doing admissions director and when I was doing social services director, working with my admissions director, I would usually always say it's like, hey, if you can also get any POA paperwork or advanced directives that the patient might already have, just to complete that initial the initial intake file for them. That's where the interdisciplinary team can have a better sense about what's going on with the patient. All paperwork can be in place. Um, Again, that's risk management, making sure you have all required documents in place as well. That can save you a lot of heartache down the road if you do all that in the intake process. Um, Accepts handoff from the marketing coordinator director. So remember in the last slide we said usually from the hospital or um, point of referral up until the arrival admission to the facility, the point of contact usually might be the marketing coordinator director liaison. Okay, when it gets to the facility, then the marketing director um, liaison has essentially done their job. They got the patient from the referral source. They're getting the patients to the bed, or they're bringing it to the admissions director. The admissions director acts as a host or hostess for the new patient to ensure a patient will become adjusted to the facility. So customer care. This is all customer care at this point. Okay. Once the admissions director liaison, admissions director, marketing director, marketing coordinator liaison captures that patient, draws them in, it's customer service from here on out. Okay. Then when you get the administrator, I mean, when the admissions director gets the patient gets in the facility, I like to do a 7-day process. So I call it a post 7-day um, admissions process where you're following that patient, you're making sure all their needs are met, you're scheduling the care plan within those 7 days. All of that was 7 days. Getting this contract signed, any financial documents you want to get that signed. That's the 7 day post. You also want to. I usually like to do the 7 day post like that, or 7 day post admissions follow up, because in doing that, um, patients, especially long-term care people, it's going to be an adjustment process for your patients when they get there. They're not at home anymore. They might not be able to go back home if they're coming from the community of living on their own to not having to be in a facility because they require 24/7 care. Maybe they're there for short-term rehab, so they're going to be there for a few days, for a few weeks, but there's a big change in their lives that they're experiencing. They're going to be in a new environment. There's going to be a lot of rules that they have to get used to, and all of that. You want to really help the patient, the resident, um, adjust through those changes. Okay, and just think of, again, as a customer service human aspect. Hey, I know maybe you had a medical event, maybe you had a stroke, maybe you fell, maybe now you're needing 24/7 care support, and it's a scary time of your life. You want to be there as a customer service support. You want to be there to help them transition through that and adjust well. Because they're going to come in with all these complaints. Oh, the food is nasty. Oh, this. Oh, that. So, and sometimes, no tea, no shade, that might be legit, but sometimes it's just them. They're having a hard time adjust. So within that 7 days, I just say it's giving a little love and tender care to that patient. Like, hey, welcome. We're glad you're here. We want you to be here. Let us know if we can do anything for you. That extra touch go a long way, and keep the heads in the bed, which stops you from losing them in the census. Okay. Speaking of census, let's talk about census. Oh, I need to remove. Hold on. So I want you to see. On. There we go. That's better. So, what is census? It reports who is in the building. How many patients are we getting paid to care for? As of midnight, meaning whichever patients were physically in the building by midnight day prior. So long-term care, we all know morning meeting. Some of you might be in morning meeting right now, on your way to morning meeting, coming from morning meeting, whatever. Morning meeting is when all the department heads, they get together. There's usually key points. Most facilities, the administrator um, be recording they will have a record of minutes, recording different minutes, basically just any major patient updates, what follow-up needs to happen today, what risk going in the building, because usually every morning every department manager should be doing their own risk management audit of the department and of the facility. um, just a quick to see what's going on, what needs to be fixed right away, what you need to keep your eye on. So the morning meeting is that meeting where all the department heads get together. They give the updates about what's going on with the patients, what's going on with their departments, any challenges they're experiencing, any follow that's needed, communication between the departments happen there, um, and just general updates about the facility overall. Um, the start of every morning meeting, though, it's going to be that census. That census is going to be so important. Why is census important? Because again, how many patients are in the building? Every bed that is filled means the facility is getting paid for that patient. Now, if they're making profit of that patient, that's a different story. But every every bed that is filled, so it means if there's a patient in that bed, yay, the facility gets paid. Okay, the way it works is it goes from midnight, the day runs from midnight 0000 to 11:59 p.m., or actually really midnight. They have to be the rule is the patient has to be in the building by midnight, or as of midnight. So after midnight, it's a new day. So that means the morning meeting of the census, how many patients were in the bed as of midnight that would cover. That means all that's the total number of patients that was in the day in the building the day prior. So, let's say morning meeting, they say the census is 180, which depending on what building. Yeah, that's a really good census. Um, that means as of midnight, the patient, the facility provided services to 180 patients the day prior. Okay, because they were in the building. Now, if a patient came out and went out, came back same day, that still counts as them being in the building for that day. If the patient goes out but does not return or is out past midnight, then they don't get paid for that day. Okay, because insurance, Medicaid, Medicare is like, well, they weren't there, so we don't have to pay you. So facility is gonna want heads to bed. They're gonna want heads to bed. Okay. Um, Census is the facility's revenue. Again, head to bed equals paid bed. For most admissions director and admissions coordinators, that's your main goal. Get the head to bed, especially for if you're doing marketing. Empty beds means no income for the facility. If there's no patient in bed, you can't get paid. So they want patients to bed. Now, of course, patients to bed doesn't necessarily mean you're making profit still, because there's some ins and outs with that as well. But generally speaking, a patient in bed means the facility is getting paid. For marketing directors, coordinators, and admissions directors, coordinators, um, that's a big part of your job, of course, getting the patients to bed. Oftentimes, you will have quotas that need to be fulfilled. So they might want 1 to 2 patients a week. Short term, it might be a little bit more. You might be looking at 3 to 4 to 8, depending on how much your facility can manage. So that's one of the things that your administrator in corporate is going to be you about. They want to get those beds filled. They're going to want you to fulfill a quota. A lot's where a lot of challenges come in. A lot of challenges come in being an administrative director and marketing coordinator, fulfilling those quotas, because you either run short, either by getting the patients in or they leave, or other things we'll get to in a minute. Okay. But that's really what a census is. So a census morning meeting, that's going to be the first thing. The first thing, unless state is in the building or survey is happening, well, then you probably would have morning meeting. And that's way more important then. But the first thing, and even then, though, that census is going to get completed, because they need to know how many people were in the building as of midnight so they can bill for that day prior. Okay. So census is very important. This is going to be this one thing. This is like the driving point for a lot of missions and um, marketing coordinators. And I will say too, this I do know I see a lot now that's happening is a lot of facilities are doing one or two approaches. They're doing a centralized admissions where the centralized admissions goes to corporate, or two, they're making the marketing or the admissions person a dual role. So the admissions person is also doing marketing, and the marketing is also responsible for the admissions processes. So I'm seeing that happen a lot too because of the staffing issues and shortages, high turnover. Turnover. I'm seeing that a lot too. It was at one point I had a position where I was the admissions director and the social services director, and I actually loved it. Like it was challenging, yes, but I loved it. I really did. And that's why I love doing this, because I love doing this. To me, it comes with its obstacles and whatnot, but I love figuring out how to make this work. And guess what? You can make it work. All right, so let's continue going. So, we're talking about census. One of the things that, of course, every administrator, every owner, every corporate executive staff member is going to want to know, why are there empty beds in the building? Nursing home, long-term care staff facilities, those of you who work in the field, we all know. Okay, look at me. We all know that owners do not like empty beds. Why? Why don't they like empty beds? Empty beds equals no income. Business 101. No income means no profit. And running a healthcare facility, long-term care facility, is very expensive. Very expensive. Okay. Um, so what are some of the reasons there are empty beds though? Patient resident hospitalization rehospitalizations. We call them frequent flyers in the field. So we have a patient who comes in or a patient of ours that goes to the hospital constantly. They're constantly in and out. The major thing besides the whole rehospitalizations and constant hospitalizations, breaking down your CMS quality measure points, is also the fact that if they're out past midnight, remember you don't get paid. So if they're out for a number of days, that means yes, you have this patient as a resident in your roster under your facility, but you're hardly getting paid for them because they're not really in the building, they're in the hospital. Okay. So this is a huge issue for a lot of facilities because a lot of patients continue to need rehospitalizations. Sometimes, and of course, there's just sometimes medically, there's nothing you can do about it because of whatever medically is going on with the patient. Is just kind of how it is. They might not be necessarily appropriate enough for hospice, or maybe they are, and then maybe they're just still not ready to go that route. But there could be a lot of medical decline, um, a lot of medical things going on where hospitalization just becomes kind of um, part of the need. Um, a lot of times, though, there are ways if we look at um, how the interdisciplinary team, the different department heads, the different departments communicate um, and do different workflows, how they assess, how they audit, how they do risk management. A lot of times, if you look at those different processes, you can fix the hospitalization process. Okay. This be a lot of observation documentation. What do we know is going on with the patient clinically? Are we talking with the doctor to get preventive measures in place? Because a lot of times, you know, we're not really doing due diligence with that. Okay. You're not, um, you're not do, doing your clinicals. And in clinicals, it usually happens right, maybe a few times a week, but usually after morning meeting, you get your Medicare meeting. We are discussing the clinical cases, these cases with the different team, with the providers to come up with different solutions to preventative solutions. A lot of the times that is not happening because there's a lack of communication, lack of workflow process in your facility. So that results in, unfortunately, patients being hospitalized and rehospitalized. You know, were there some, and I know this is gonna sound so, because this is the thing that I know a lot of people hate healthcare administrators say, but what are some things we could have done differently? Um, because I don't think it's necessarily putting ownership or responsibility on the staff, but it is a risk management. It is a question that you have to ask in terms of okay, well, what are some things that I wouldn't say what things you could have done differently? What are some different things in the process that could have been improved? Take it outside of a staff role or a role or responsibility or a department. What are some things in the overall process that can be done differently? Are there some things that the facility that providers can do uh, to help prevent the need for hospitalizations? Okay, if you know you have a patient going to the hospital constantly for respiratory issues, respiratory failure, whatever, are there some preventative measures you can do? Are there some there's some medication checks that you can do? Talk to the doctor and see, hey, we want to need to really get this patient from stop going in and out of the hospital. Can review the medications. Are there there are very different treatment options we can look at? Okay. Not only is that going to save you money in the long run, Okay, but it's also the patient's going to love that because who wants to continue to go in and out the hospital? Okay, unplanned community discharges. So this is the dissatisfied patients who get there, whether it be short term, long term. They get there, they don't like it, they want to leave. Um, this sucks for short term because um, it is not as bad for short term because the short term is a revolving door. So patients short term, they're in there for like at most 20 days to maybe usually 20, 30, maybe 40 days, but usually 20 to 30, at least no more than a month. Long term, that's the patients you're getting that are aging in place. So once they're there, they're there. um, so a lot of facilities, short-term and long-term rehab, short-term rehab and long-term have an issue with these unplanned discharges for patients who just don't want to be there. Um, Transfer to other facilities, you might get a patient, they might not decide they want to be there. They might want to go to another facility, either again from being disgruntled or not liking the place. Sometimes too, you might get the case where they want to go to a facility that's closer to family or friends. Um, Now, with those two, the unplanned community discharges and transfer to other facilities, that's where when you're talking with the initial referral, that's where you get build or talking with the patient during the initial contact. That's where you can start building rapport to really gauge if that patient's going to be a good fit for you. I mean, for the facility, and if they'll end up staying, which we'll get to a little bit later. Inability to provide needed level of care for patient. So how many times have we or the facility accepted the patient and just found out there was too much that they can handle? This is mostly common for patients who might have severe mental illness or psychiatric issues. You might have accepted them because of a medical issue. They got there, turns out they're just completely um, unrestrained. They're hitting staff, they're throwing things, and your facility just isn't uh, staffed or trained to deal with that. Um, and that's kind of the common thing with that, particularly inability to provide needed care level of care, is because with patients, we're coming across these patients who are in um, many different needs, and after experiencing so many crises, both medically, socially, all of that. Of course, there's denial of coverage. With this, I'm thinking managed care. Managed care. We all love managed care, right? So, with that, just a general breakdown for managed care, especially managed care Medicare. Generally, how that works is generally is how it works is the patient before the patient gets there, the insurance plan, that's the managed care plan. The insurance provider needs to provide the facility an authorization that they can render services. Okay, so that whole process of getting the authorization, the initial authorization in itself is a headache. But of course, when you get the initial authorization, yay, that means you got a patient coming to the building. You're going to have a head to bed, right? Wonderful. Well, guess what? You know how managed care works. Every few days, you got to submit updated clinicals. At some point, managed care is going to say, okay, that's enough. They could go home and receive home health from there. They basically cut you the notice of non-Medicare coverage. Okay, they cut you, and then basically, you think you might have that patient for another week. No, you got them for another 2 or 3 days. Oftentimes, the managed care players doesn't even give you a full week. They might give you at most a week, maybe a week and a half. But you got Barbara, who is a 80-year-old, 70-year-old woman who broke a hip. We ain't gonna be able to heal it up in 3 or 4 days. Okay, we want to be realistic, but so dealing with managed care, denial of authorization because denial of coverage means you're not going to get paid. The patient's not going to, or the patient's got to be private pay, which they can't afford. So again, that means you're going to have an empty bed then because the insurance isn't paying, the patient can't afford to pay, so it's empty bed. All right. So some leak points identified in the census. Census leak points. Okay. Unplanned discharges. Okay. Patients, you got the patients in, they didn't like being there, or they want to go to another facility where they're going to be closer to family, what have you. Hospitalizations, rehospitalizations. Patients constantly in and out the hospital, out past midnight, out for a few days. That's where you can go back and look at your clinical team, look at what's going on. Like, okay, well, what are some different treatments we can do? Are there treatment options we can do? Can we make some medication revisions? Um, because that is the role. That's what's the role of the facility. Okay, the role is to keep them out the hospital. So we're actually charged with doing that, and that's why I say you got to lean into that. Lean into it. It's a case study. It's an active and ongoing case study. Okay. Um, Transfer to other facilities. We did that. Inability to provide care. Again, a lot of times we're seeing a lot of patients that we get the patients, find out they have a whole wealth of issues, whether it be medically or mentally, that we just can't deal with, and in some cases the facility can't afford, especially when it comes to that medications. And then denial of coverage, no insurance coverage, inability for the patient to pay privately. Okay, so that is your empty beds. That's your leak points, with some good tips on how you can alleviate them. Okay, the admissions pool. Now let's talk about the admissions pool, because hold on, I need a break for this one now. The admissions pool. Okay, so what is the admissions pool? Generally refers to the consumers, patients available for services at the facility. Okay. Facilities providers make profit from providing healthcare services. That's key. Remember, head to bed equals paid bed. Empty bed means no income. The business of health, we live in a capitalist society. The healthcare industry is no different. We want to make profit, especially because our services is very expensive. Our investment is very expensive. So yes, you want to make a profit. Okay. Um, the admissions pool is I like that's what we heard in healthcare. The admissions pool, potential patient referrals. Those of us who get patient referrals, long term care, is where we find our patients. That's how we get patients to the beds, or the place where we get the patients to the beds. Okay. It could be from that includes hospitals, clinics, providers, community sources, what have you. Okay. A facility's admissions pool will depend on its public and community image, appropriate level of care it can provide, and license to provide. Okay. Number of patients it can hold, certified beds it can legally hold patients in. So, how many Medicare and Medicaid certified beds do you actually have? Location, and I hope no one's breaking that rule. Location of facility, location of referral sources, hospital clinics, providers I just mentioned, and insurance networks in and out of network, to name a few. So the admissions pool, in essence, is shaped by the reach of the facility's brand, the reach of the facility's um, existence, which we'll get to a little bit. So for marketing directors and coordinators and admissions director, this is a great opportunity where you can learn, or this is the next few slides are going to teach you how to manage your admissions pool, because there are ways you can um, that you can coordinate, or that you can rebrand your facility, rebrand uh, your whole marketing structure to expand your marketing pool, to improve your marketing pool. Okay, but you have to understand which the admissions pool is. This is where you get your customers. This is where long-term care facilities get their patients. This is how you fill those beds, your admissions pools. Okay, one of the things about admissions pools, the admissions pool, um, and we can go to the next slide. And this is a admissions pool from a risk management review. It is very unpredictable. Okay, it goes up and down. You don't know what patients you might get. Um, we always, of course, see an influx maybe around the holidays, especially psych facilities around the holidays. If it was a event where it was the first freeze of the winter or the first cold night of the where there's black ice or something, you might see a lot of referrals coming in for broken hips and legs and whatnot. Um, so the admissions pool, because it's so connected to the community, what's going on in the community, and public health, there's a lot of variables in it, which makes it very unpredictable. The level of care needed, again, thinking it back to how the different needs that patients might need, especially when we look at the need for mental health. That's usually kind of one of the number one, I won't say issues, but the number one um, with challenges that long-term care facilities are facing in their admissions pool is gaining patients who not only need extensive medical um, support and care, but there's also mental health support that's needed too. And a lot of facilities do not have a mental health behavioral program structure in place to deal with that. Okay. Um, Risk and liabilities for facilities and licensed staff. Okay, so if you're accepting these high risk patients where you don't have the behavioral support, the level of care of need is too high, which is why they're probably going into the hospital to begin with, because you're losing money, you're not making money. Um, this creates a whole bunch of risk and liability for facilities and licensed staff because guess what? State's going to come in, they're going to do their review and survey, they're going to give you fine and all that stuff. Okay, if your facilities have enough costs, we're living where everything is increasing. Cost of living is going up. Prices of services going up. Everything is increasing. Now think of these increased fines that facilities are paying for services, getting low reimbursements, having to fight for patients, so you're hardly making any profit, staffing issues, um, with the need for talent, and then the need for talent comes with the need you got to pay them. All these increased business costs against fines, audits, accounts, and collections because patients you don't either get reimbursements or the patients can't pay, increasing overhead costs. All of this these facilities are facing. This is why it's important to control and manage your admissions pool. Because controlling and managing your admissions pool allows you to control that revenue, your revenue, control your revenue and profits. Even though it's unpredictable, there's a way you can control it. Remember, if we go back, I want to drive this point. A facility's admissions pool will depend on its public and community image, appropriate level of care it can provide and license to provide, number of patients it can hold, certified beds legally, location of facility, location of referral sources, insurance networks. Basically, what is your building's profile? That's going to be your marketing profile. You want to build your marketing profile because then that's going to influence what your admissions pool can look like. Okay. So, what do you do and how do you do that? So, let's talk about creating a patient template. Okay, use data gathered during assessments to define the types of patients your facility can appropriately serve. This becomes your patient template. Now, remember what we just said about the admissions pool, level of care, community engagement, all of that. Sounds like a facility assessment, doesn't it? or a good start to a facility assessment. Okay, one of the things I find in this field is that so many administrators, so many management staff, even corporate staff, even owners don't understand their business structure. Again, it goes back to this point. You just think, oh, I have a nursing home. Oh, I provide short term rehab. Oh, I have therapy. Oh, I provide medical services. Or I provide long term care. So, okay, the patient's just going to flooding in. That's not how it works. That's not how any of this works. That's not how any of this works. Okay. Again, long term care. How do I describe it? And I don't want to get into it right now, that point right now, but I'll just say this: long term care um, requires participation, requires innovation, requires research, requires data. We have a wealth of data at our hands, a wealth of data. Okay, the patient template, what you want to do is you want to assess your facility. Okay, it's a quick general, it's a marketing assessment for your facility, but it's not just for me. I don't think it's also just marketing. It's also, sorry, it's not just marketing. It's also a good way just to help understand your business structure and level of your business. How do you do that? Let's talk about it. So the patient template, admissions and marketing, pretty much any the whole in the field. We get the demographics of patients. We get where they live, insurance providers, age, diagnoses, um, hospitals, the different providers they go to. So much data. Think of the medical records, all the information you get in your medical in the patient's records. Administrative side, we get their social security information, the income, um, social, social emotion. We get can get very detailed personal information about their lives because we're providing care, patient centered care. Okay, we have data at our hands. You want to use this data to one use it to assess, do a quality review of your facility, of your processes. With marketing and admission strategy, the patient template is basically you're reviewing, okay, your facility. You're seeing what's your main purpose, or if you want to do, if you're a long-term care facility, maybe you're like you're doing focusing on dementia um, and Alzheimer's care. Okay, so that's going to be your main patient profile. I mean, the main patients that you were looking for. Maybe you're in, um, let's say, a middle class neighborhood. Okay, you're in a middle class neighborhood. You're providing dementia care. Um, you have maybe one or two hospitals. We'll say one hospital, at least one hospital within your geographic area, which is usually always the case. We call that the feeder hospitals. That's the hospitals. Usually, your nearest hospitals where you get the most patients. So that's your major feeder hospitals. Some facilities might have two or three feeder hospitals. Okay, so you're looking at all that, the geographic, your community, in-house. You're looking at, okay, what service, what care can you provide? So can your facility do trach patients? Can your facility handle, um, provide mental health and psychiatric support? Can your facility handle G tubes or different things regarding that, or different clinical medical, basically very medical or clinically diagnoses? What are your facility specialties in providing care in? Okay. Um, what you're also going to want to look at your past survey results. What tags have you received in the past? What have been your major points where you continue getting fines? What's your risk? Okay, basically a SWOT analyst. You want to perform a SWOT analysis of your facility. From that, you'll then want to, okay, what's going to be the patient profile, the patient that we want to look for, and doing our marketing when looking at referrals? What's the template for that? You know, what's the age range? What conditions can we manage? What social and psych needs can we manage? Are we going to have to provide the support to manage that? Doing all of that with each and every patient. So you got the patient template, which is the patient template, which is again like a guide for marketing admissions directors to use. Like, okay, you assess your facility. This is the patient we can ideally manage and make profit off of, based upon the services and risk we deal with on a day-to-day basis. So admissions and marketing will use that as a template to look for patients who fit that template or close enough to it. Because it's not always going to be perfect, obviously, again, because the admissions pool is unpredictable. But again, you got a template so you know what you're working with. Okay. You can use that template too for every referral that you get, to use it as a quick assessment. Okay. The template helps you evaluate new referrals with risk and alignment in mind. So the patient template, you review, you do an assessment of your facility, both of internally and externally. Um, you identify the risk, you identify the strengths, SWOT analysts. From there, you create, okay, based upon all of this, what patient can we accept that would give us reduced liability, reduced risk, that we can care for without with limited issues. Because remember, we want to do preventative care. That's my whole thing. You want to engage as much preventative care and planning as possible. So the template can help you do that. Can the facility legally and ethically provide the required legal and level? I'm sorry, provide the required level and scope of care to the patient. That's going to be one of the number one questions you want to ask. Why? Because down the road you don't have to deal with complaint surveys, fines, issues dealing with the patient. You don't want to deal with all of that. Okay, that's only one of the questions you want to ask. Can the facility legally and ethically provide the required level and scope of care? The second main question is, can the patient's expectations be realistically met? Okay. If Barbara is 85 years old, no, if Barbara is 98 years old and she fell and broke her hip, not to sound insensitive, we're not going to have Barbara up and walking in the next week or two. Barbara came to us with a broken hip. She was already having declining health. She had a stroke last year. She barely had any strength. The family was saying she was falling every day to begin with. Barbara's not going to be up and running in the next week, in which sometimes the families can have the expectation. I'm not blaming the families for that, because we're, again, customer support. We're dealing with loved ones, but the reality of that happening, we know in healthcare that's not going to happen. You don't have to be clinical to understand that's just not going to be the case. Um, so can the facility meet the family and patient expectations? A lot of times, I know a lot of facilities say yes because they want the money. But again, you get the patients in. Now there's issues. They're doing all this, causing all these complaints. They're getting you riled up. It's just always a mess with them. Can you meet the patient's needs, expectations? The patient's needs is the first question. Can you legally and medically provide the scope of care? That's how you reduce your fines. That's how you prevent any when they get in. You have to, you're getting on top of that right now. You're preparing for the patient before they get to the building. So that's why if any issues arise, that's where you can deal with any, maybe prevent a hospitalization. That's where you can prevent an unplanned discharge. You can get them adjusted to the building. Are you gonna be able to adjust this person to the building so they can receive services, so they can, you know, go through a treatment, short term discharge them, get your reimbursement, long term they become part of the community. Okay. So do the referral opportunities align with your facility goals? Again, remember I said a lot of times what I find is a lot of facilities do not have a clear understanding of their goals, of their business structure, how their business works. So, what are the goals you need to that some facilities might have? Now, good thing about that is doing that SWOT analysis to get the patient template is also a great way to identify what goals you want to do. So, let's say we did a SWOT analysis of a facility, long term care facility. Same, we can do the same one. So, facility, let's say it's a 150 bed facility, mostly short term, some long term, for older seniors with dementia, providing dementia support, middle class neighborhood. Um, we did a SWOT analysis, finding that, um, we're finding that a lot of what we're finding in the admissions pool, a lot of the referrals that we're getting, maybe, is that we're getting a lot of patients who need respiratory support, or maybe there's a lot of patients, a lot of stroke patients, post-stroke patients now in the admissions pool. But maybe now your facility, maybe they can't don't have the or a common one, maybe there's um an increase in related cancer diagnosis in your admissions pool or in the community, that's requiring needed support from long-term care facilities. Maybe your facility has only been maybe only dealing with dementia patients, but maybe now you're seeing from your SWOT analysis, from kind of analyze everything that you're saying, like, oh, we denied, um, maybe out of this week's referrals, we denied 6 out of 10 of those patients, or 4 out of 10 of those patients because of a level of care, or a diagnosis that we couldn't um, provide or care for. Way, then, a goal we can plan to maybe, hey, can we improve that? Is there a way we could get staff training involved to improve that, or get staff developed on that so we can start accepting those patients? Great way to increase census. What are some new areas of development and opportunities for your business to expand in services in scope of care? Could that be staff development? Could that be? Could be anything really. But depending on the assessment, you can identify stuff like that. Um, Attract more Medicare patients. That's usually always the number one goal for a lot of facilities. Expand services of level of care, which you just talked about. How can you expand services of level of care to accept more patients and get that head to bed? Okay, use admissions marketing data as strategic asset. Key data points. Okay, referral sources. Who is your referral sources? Hospitals, clinics, software systems that you use. Diagnoses. What are the major diagnoses that you're seeing in the admissions pool, or that are coming in from your accepted patients, or your denials? Payer types. What are the common payer sources that you're getting, um, either referrals or accepting and denying? Demographics. Where are the patients coming from? Um, age range, um, cultural statistics, things of that nature. You want to use this data to spot trends and top referral payer sources. Okay. Where are you getting your most referrals from? Who, what insurance plans or providers are giving you the most patients, or you're having the least problems with? Identify quality and training needs. Training needs. How can you upscale? okay, which we just kind of talked about. So remember the expanding service. So you do a SWOT analysis of your building or of your facility. You find that there's some areas or level of care that you can expand upon. What training needs to happen? How can that happen? Because again, improving that could get you more patients. Assessing what strategies work. Um, how does your referral process work? How does it flow? Keep in mind that a faster referral response usually does mean more admits. Okay, you want to get all this data. Again, data coming from the SWOT analysis, from the demographics information that admissions, and the admissions and marketing directors get from talking with the patients, the hospital records. Get all that. Use it to do a greater SWOT analysis or assessment of your facility, of your marketing, of your level of care. Compare these findings to business goals to drive smarter decisions. So again, you're gathering all this data. It's basically just data collection, research, looking at the data, identifying the trends, building your marketing strategy based on the data that your facility is getting. That's how you build a smarter marketing strategy. Okay. Referrals should be reviewed by the entire interdisciplinary team. Engage in pre-planning discussions around the patient's condition, care expectations, and potential realities. Identify the patient's primary concerns and goals. Assess continuity of care needs. Sorry. Assess continuity of care needs. What services and supports are required for short-term and long-term, in the short-term and long-term. Determine which key disciplines will need to be involved and importantly identify the payer source who is covering the cost of the services. This is so important when we're talking about admissions and marketing. Admissions and marketing is not just for the role of the admissions and marketing coordinator. It is for the entire management team of the facility. When a patient is coming in, or before a patient gets in, the team should know that patient before they get in. You should know based upon the conversation or the communication that from the communication that the admissions director, marketing director have had with the hospital staff, with the patient's family, if applicable, and with the patient, with the medical records, with what's going on, with what your facility can handle. It's a case study. It's a case study. You're doing a case study for each referral because one, you're doing preventive planning. You're doing preventive assessment of the patient. We got this patient coming in. What are going to be their needs? You're not going to know. Are you going to be able to know their needs? You can anticipate. You can anticipate. Okay, there's a way to do that. Getting the team involved in doing this early is a great way, again, to alleviate the leaking census points, to stop the hospitalizations, to stop the disgruntled or dissatisfied patients from leaving. Even if you might get a patient who's at your facility, but they might want to transfer to the facility closer, guess what? You do this, you go in with that good customer support. They might say, well, yeah, that'd be close, but you know what? I just like the service here. People will choose the service over your facility over maybe just the need of wanting to be close to families or close to the facility to be family. Because hey, family, they could drive the extra 10 minutes, 15 minutes to be here. Because they love your services, your staff, and you've done a good job with building your workflow processes and admissions and marketing. This is a great way to stop deal with risk management in terms of making sure there's not going to be any complaints. You're not going to go across any issues that could get you a fine. Okay, and make sure again we're meeting the expectations of that patient realistically, um, and in the best manner possibly. Okay, so we're gonna almost done. The holistic care model. So human-centered marketing. So take a little bit about 5 minutes just to really spend time with this, although I really want to spend more time with this. But again, admissions and director, admissions and marketing directors, we're meeting the patient in basically a medical crisis to some degree. If it's long-term care, maybe they just had a medical crisis and they can't live by themselves anymore. They're going to need 24/7 care. That's going to be a big change for the patient. If the patient is going to be in need of short-term rehab, it might be short-term. They might only be at your facility for a little bit of time, but it's still a change. They're not going to be at home. They're not going to be in their usual environment. Okay. You want to approach this from a human-centered marketing approach. Human-centered marketing means I don't want you to give up the quotas. The quotas are important. You got to meet the quotas. But this is a strategy about how we're going to meet those quotas. One of the things as a healthcare administrator and public health specialist in this field for over 15 years is I believe and truly follow the holistic care model, which says that the wellness, health of a person is composed of the balance or imbalance of their physical, social, emotional, and spiritual elements. Okay, where you're looking at your patient, where you're looking for new patients, you're going to look at the wholeness of the person, not just look at their diagnosis and oh, that's going to make us money because we're going to get a good reimbursement rate on that, or just to fill the head to bed, or to get the owners off your back about the quotas. Use the holistic care model because that's going to give you the full picture of the patient. So many times we're so busy looking at the payer source. It's a Medicare patient. We're looking at the Medicare dollars. That we're not doing our full due diligence to do a full assessment of the patient, of the referral, and to look at the person as a whole. Okay, yes, they are here to be able to use money, but they are still a patient. They're still a person. They're somebody's loved one, somebody's grandma, grandfather, dad, uncle, sister, brother. Okay, when you're meeting with the patient, you want to or look at the patient records, um, medical records, you want to ask yourself, what will the patient need in addition to any medical and therapy services? You want to ask that question off bat. That you want to be in your head off bat because again, thinking about your patient template, you want to incorporate the wholeness of the person. Doing that is going to alleviate the leaky points and any risk violation or compliance fines or violations. Okay. A good way to do this is through motivational interviewing, which basically is a person-centered conversation where the patient is the point of attention. When I went to meet with patients or new referrals, it was basically, "Hey, I want to hear about you. What's going on with you?" I was asking, Tell me in your own words what's going on with you." I just let them talk. I let them vent. I let them rant. I guess I wanted to know. I need to know as fully what's going on because there's the medical records. That's what the family says. That's what the social worker discharge planner says, and then that's what the patient says. That's the raw data right there, and that's the data you really want. If you are a marketing or healthcare coordinator, I'm sorry, marketing or admissions director or coordinator, you should be doing on sites. I like I know we live on sites, or if you can't do virtual or phone conversation, but there still be some connection. In some cases, though, I'm going to still stick and say you need to do on site. Some you just need to do on site. Honestly, I'm just still comfortable on site for referrals. I like to go to the hospital. I want to see the patient, see the family. I like doing that because um, it's a very human approach. So I like doing that because again, you're putting the marketing person is the face of the facility. Put a face to the name of the facility. Your customer support. Customer support is how you're going to get that patient in. And even with customer support doing it this way allows you to analyze before you take the patient, can we handle the patient? Don't just look at those Medicare dollars. Can you handle the wholeness of the patient? Okay. So in doing that, we're going to build trust with the family, the patient and the patient family. Usually, this is a great way because usually, again, the marketing admissions person, again, if they're kind of if you're doing a dual role, it'll be just whoever's doing marketing. It's usually the first point of contact for the patient or the referral source, the patient. Okay. Another thing you want to do is when you are discussing advertising your facility with the patient, be open and honest and upfront about what's going on. Sorry, what the expectations are, what's to be expected. This includes financial. Okay, managed care. Managed care. Let's talk about that for a quick moment again. Usually, we already know the patient only gets 20 days if you're lucky with no copay. After that 20 days, there's a copay that's applied, depending on the situation. But in some cases, after that 20 days, there's a copayment that's applied, very costly copayment that's applied, um, that the patient has to pay. That's assuming, of course, that they get approved children. Have those conversations up front with the patient there. Hey, this is how insurance works. If it's going to be long-term care, hey, this is how Medicaid or how insurance pays for it, and this is why you're going to have to earn your income. Talk about all those different processes. Talk about the rules of the facility. You know, talking about what's allowed to be allowed to be in your room, what's not going to be allowed to be in your room. Start having those conversations then and there. Okay, because by the time you get to the facility, it's a liability. You want to manage the liabilities before they get under the roof, because it's not a liability if they're not under the roof. Okay, if you know you have Freddie long-term care. Let's say we're doing long-term care now. Let's say we're doing a psych facility. Um, or let's go back. Let's go back to the nursing home, mom and pops for basically dementia care patients, um, in the middle class community. If you get a referral, or can you imagine getting a referral or a patient at a nursing home where mainly the population is mainly 80, maybe 70 to 90 years old, mostly might be on the walker, wheelchair, dementia, so they're just confused. Can you imagine accepting a patient then who's 25 years old, maybe has a substance abuse problem, likes to hoard lighters, and might be known as to be a pyromaniac? Can you imagine? Can you Can you imagine that? Can you imagine getting that patient under your facility, in your facility? Can you imagine the same facility getting a patient, um, let's call her Jane Doe, 35 years old. She has chronic schizophrenia, no fault of her own, but unfortunately, part of her behaviors includes randomly punching people or fighting people because of paranoia. In a nursing home where your patients are 70 to 90-year-old patients with dementia, mostly in wheelchairs. Can you imagine what that would look like? I'm not over exaggerating either. Oh, I have stories. I have stories. Can you imagine? You want to handle your liability before it gets to the building. Trust and believe me, you do. By the time they get to the building, there's a fine. Plus a whole bunch of other stuff that you think you might be getting profit off this patient. You're not at all. In fact, they're costing you money. Oh, I got stories. Okay. um, because I did mention on-site visits. Again, I love to do on-site visits because that's where you really build a rapport and you get to put eyes on the patient and do your own assessment and scope. So welcome getting the will. Another thing too with this, I want to say too, is for patients who are hospitalized, rehospitalized, go and visit those patients. Take a goodwill card that's maybe signed by the department heads or different friends or staff. Go and see especially if they're long-term hospitalizations, the ones who might have, You thought they may have been out for a day or two, but they're actually been out for a few days. Go and see those patients. That says so much. One, not only is going to make that patient feel good and know they made the good decision. If they're a new patient, maybe just got hospitalized, they're definitely going to want to come back to your facility. You're like, wow, that's really that human-centered marketing. It's also going to be a great attraction to other potential residents because guess what? As other patients and staff members see, or hospital staff see, wow, you're coming to really visit your patient who's been hospitalized to make sure you keep bringing them just a goodwill card, just to even see how they're doing. That says a lot because that's something you don't see. Other patient families are seeing it like, wow, they want to know. So here's the thing: we want the patients for money. Okay, we want again. That's how our business works. We want the patient for money. We want to get the profit. We get the head to be able to get paid. Think of it from the consumer's aspect. They want a place where they can trust their loved one or themselves to be cared for and loved. Think about it like that. Think about it like that. So if you're doing that, if you're following up with your patients in the hospital who are hospitalized, re-hospitalized, go and see them. Take a goodwill card. Talk to them. See how they're doing. Again, this is also good too because again, you can be managing the readjustment when they come back, because especially if you're working with dementia or Alzheimer's patients who might be getting hospitalized, or those patients who might be on the fence. Because remember, if they go to the hospital, they can technically just say they want to go to another facility if the facility takes them. That's a whole different another ballpark around that. But this is how you can keep your patients in your building. Okay, because they know they're going to get good care. They know they're around good people. Okay, character really goes far. It really does. Okay, last but not least. Uh-oh. Welcome to live. uh, your local healthcare so community engagement outreach. This is where number one, I want you to learn your local healthcare ecosystem, your local health ecosystem. Who is your local health ecosystem? Hospitals, clinics, private providers or providers in general in the community organizations, shelters, food pantries, charities, nonprofits, churches, places of worship, local and state health offices, uh, grassroots organizations. These can also include alderman, government, and representative offices, community leaders, and local event sponsors or different local events that happen. Okay, why do you want to do this? Because again, marketing strategies of just seeing there because you have a in-demand service. You do have an in-demand service, but there's many different options. Okay, truthfully told, there are a lot of different many of these options that are better than the other ones. There's a reason why certain long-term care nursing home facilities they have wait lists, and other ones can barely get an admission or two a week. Okay, community engagement. Who are you? What's your brand? Okay. Are you known in the community? This is a great way to get easy referrals. Easy referrals. Community, going to local events, meeting up with these different personnels and providers at these different places or staff, let them know, hey, we're here. So in case you need this service, which oftentimes I can tell you, working in community, the different community organizations, there's oftentimes it is very helpful, or oftentimes I've come across patients, clients, um, community, uh, what have you. I can't think of the word now. It's dropped my head. But I've come across potential patients in community doing community work who do need long-term care or short-term services. Okay, we are in an in-demand field. There's no question about that. How you leverage and build your census is to build your community um, profile and engagement. Okay. Also, think about doing this: open houses. Invite people. This is a great way to just do open. Do tours. Okay, you could do one Saturday a month, or once a quarter. Have an open house where community, potential families, potential patients can come and explore, meet the different staff members, view how you do things. Easy engagement. You could also do in-house events. Okay, family nights, theme nights like talent shows. I know some more activities, but you could use that as marketing strategies. That's where you take the picture, put it on Facebook, but also again make it, invite families, invite different community leaders, get the community involved with your facility, let them know you're there, because I promise you, at some point in time, they're going to need come across a person, whether it be a loved one, a friend, whoever, who's going to need some type of support or service that long-term care and short-term care offers. Just think that's clear, easy marketing. Okay. So, does your community know you're there? Okay. Oh, and then I promise you, this is the last one. Does your facility have a digital footprint? Okay, digital marketing. We are now in the age of social media, of AI, of just everything technology. I'm still amazed that, again, most facilities only have a Facebook. And the Facebook only, again, posts various sparse pictures of different resident events. Usually it's either Christmas or Easter, Veterans Day. You might have your Nurse at Home Week, Nurses Week, stuff like that. There are some good ones that do like follow the different like healthcare, public health memorial and observation days and weeks and whatnot. But does your facility have a presence on social media? Because we're all on social media. Everyone's on social media. No matter the industry, personal or private. Let's be real. Some of your staff members be on their phone all day on TikTok, on Instagram. let's keep it 1,000. Some of you probably on your phone right now, or going back and forth between your phone while at work, while looking at this, or you probably do it at work. Social media. It would be crazy for you not to have a social media presence. Free advertisement. Free advertisement. You don't have to pay for it. Free advertisement. With that, also landing pages and websites. Now, one of the things when I was admissions director, what I did within my emails is called Linktree. Linktree, I created like a quick contact form, and I created a quick blurb about the facility that I was marketing. Linktree allows you basically to build a landing page, and a landing page is basically just a click. You could click the page, and you can build out basically like a mini website. Didn't need a full website. I just wanted to get a quick blurb about my facility and the services we offered, and a quick contact form that only took name, email, and phone number. Nothing else, because you still want to follow HIPAA law and compliance, and I didn't need to be complex. I did that way either because so I can have hospital discharge planners, whoever, possible referral points, reach me or contact me, and I can have community referrals, whether it be from community leaders or from patients themselves, respond respond to me for inquiry and to get into admission to the facility. I built a link tree with those two links. I put it in my email. I can send it to as a text message to my different referral points. I can even do it to patients, send it to patients. On social media, Facebook, you can add that link to your Facebook profile. You could create an Instagram page, do that. With everybody, all your staff members being on TikTok, have one of them set up a TikTok or set up a TikTok account and start advertising on there. Have your link there. Okay. When it comes to marketing, you want to touch every possible scope you can. Facilities are not touching this scope enough. I see these outdated, bland websites, completely outdated because the website doesn't look nothing like a facility. That's a different point itself, but that's not even the real problem. The issue is you have to expand your social media presence past the Facebook. Okay. Then on top of that, we want to utilize social media to attract the patients to us. You can host free webinars available for participants to join and virtually ask questions, like something like this one. Utilize quick access to contact forms to get information quickly and directly for fast referrals. Referral turnover. That's that link, that little link I said I did when I would put in my emails, text messages. I had an Instagram page where the link was there. On Facebook, the link was there. I had that link accessible. So whether you're scrolling on Facebook, come across this, because again, everyone's going to need long-term care support at some point. Everyone's going to need long-term, short-term care support. It's in demand. It's a service that's in demand. You're in a great field to do that. You got that, but you got to keep people to know you're there. You want people to come there. Directing, you want to direct it to potential consumers, and this is a great way to build a digital portfolio. Um, so again, this would be something, having an Instagram, having a Facebook. That could be something where you're talking to the different family members, the different patients, the different referral points, the discharge plans and whatnot. You could give them your social media. Hey, look at our social media. Have that speak for itself. Got it. Digital marketing. So I do not see this enough. I do not see this enough. Build more than Facebook and build your social media platforms. So we made it, y'all. We made it. We made it. We made it. If you enjoy this, please like, follow, and share. And tell your friends about it. Tell professionals about it. So we can get the word out so we can really start transforming healthcare. So key takeaways from today's webinar. Leverage data and smarter marketing. I want you to use facility and community data to design targeted, efficient marketing strategies that speak directly to referral sources and patient needs. Standardize the admissions process. Develop admission data-driven templates, i.e. patient template, which we discussed, to guide smarter, cost-effective decisions and ensure consistency in your admissions workflow. If you get stuck on this, just think SWOT analysis. Treat referral management as a team effort. Admission success begins before the patient arrives. Adopt a collaborative referral management approach to ensure your team is prepared clinically and logistically. Build trust from the start. Establish rapport and trust early by actively listening, being responsive, and following through. A confident patient and family are more likely to choose your facility. Know the community you serve. Build your visibility and credibility by learning about and engaging with your community. This helps identify service gaps and strengthens relationships. Maximize social media presence. Use social media marketing to highlight your facility's culture, services, and success stories, turning digital visibility into real world referrals and admissions. And there we have it. So again, I hope you enjoyed this today. Hope you enjoyed this presentation, this free webinar. Thank you so much for joining. If you want to know a little bit more about me, again, my name is Leeander Alexander. I am a healthcare administrator and CEO of Edward Lee Consulting. Please check out our YouTube, Edward Lee Consulting, for more free webinars and other content as well. And you can reach me at lalexander@edwardleeconsulting.com. Again, I hope you enjoyed this presentation. Thank you all for coming. Share, like. And until next time, take care. Thank you.